about SALSA because obviously that is a topic that's dear to my heart. But I thought with Dr. Omer's presentation or actually workshop from Friday, I thought I'd actually change this a little bit and talk about all the methods of minimally invasive surfactant because that's really where we should be going in medicine. And I'll get to the SALSA, which is again a term that's dear to me, not only because I'm Latino and I like to salsa, but really because I think it's somewhere where we really should end up. We want to be try and do all these minimal invasive methods. People always fear when I go and give these talks. They talk about, well, if you start doing all these things, then all our trainees will forget how to intubate. Well, but you got to think about the patient, right? We're all here for the patient. So let's learn about minimally invasive surfactant. So no conflict of interest. So we'll do this as some cases, okay? We have this 36-weeker gestational age, born with preterm labor. This was in the time of COVID, so this is a positive COVID mom. She also had diabetes. The baby has some retractions, some grunting. It's admitted to the NICU. Those are the settings, and the baby's placed on CPAP. And we continue to retract. We're on FiO2 of about 45% with a respiratory rate you can see of 65. The ABG obviously showing some respiratory acidosis, a little bit metabolic as well, maybe. And again, we have this respiratory distress syndrome. So should this baby get intubated, placed on mechanical ventilation? Should we use surfactant? And how should we use that surfactant? Okay, these are questions that we're constantly asking. And again, for some of the easier extreme cases, you know what to do. But these cases where you're somewhere in the middle, where you'd say, should I intubate or should I not? Should I give surfactant, should I not? These are the cases that I want to talk about because now we have ways to be able to do this minimally. So everybody knows insure. It's been used a lot. It's been studied a lot. And the idea arose with basically, it's not a protocol. There wasn't a study. There was not an insure study per se. It was basically the idea of, well, if we normally just intubate and stay intubated, but we know that the longer you're intubated, we cause bronchopulmonary dysplasia. Well, what if we don't intubate? We just intubate, we give surfactant and extubate. That's the idea. It's a very simple idea, but it actually did show, and it actually does work. But you have to keep in mind, we are still intubating. We're still going through the process of using a laryngoscope to insert a tube. The difference is that this time you're inserting that tube, you're not placing any type of tape, you're not securing that, you're literally inserting, you're giving your surfactant, and what's always hard for everybody is that you have to extubate, okay? I get this all the time where our nurse practitioner will go ahead, I'm not talking about that, we're amazing, they're amazing, we have great relationships, but sometimes I'll hear, yeah, we went ahead and insure, and I said, okay, so, you know, the kid's extubated. No, we're gonna watch him for 3 hours. That's not insure, okay? And some people like to call that a modified insure. That doesn't exist. If you're going, you don't have a modified heart attack. You either have a heart attack or you don't, okay? So you cannot have a modified insure. You either insure it or you don't, okay? The extubate is really important. The study from Isayama in 2016 did show that we actually do decrease the risk of bronchopulmonary dysplasia and death when compared to intubating and staying on mechanical ventilation, okay? However, the Bishop in 2020 shows that this is only 33% effective. That means 1 out of the 3 babies that you do this for, it actually works. The rest actually had to stay intubated and on mechanical ventilation. One caveat to that is that sometimes it's not the study, it's us. I already talked about that. We say, well, I don't know if the baby's gonna do well, so let me just keep it intubated, okay? So that's something just to keep in mind with that 33% effectiveness. When doing the meta-analysis by Isayama, I already mentioned, you can see that for chronic lung disease and death, you see that it's just barely to the left, so it does just barely show effectiveness. And what's most important, that it doesn't actually change the risk of pneumothorax or IVH, severe IVH. So again, it is something that can be used, and if you haven't done anything else, that's what you should move towards and ensure. But I'm gonna show you something even better. Case 2, we have a 28-weeker with gestational age, born again, preterm labor, mother again, was tested for COVID, but she is negative. She does have obesity and uncontrolled chronic hypertension. This is very similar, same story all over the world. The infant did well in the delivery room and was admitted to the NICU with a low FiO2 on CPAP. But about an hour later, the baby starts having some retractions, is placed on non-invasive positive pressure ventilation with an FiO2 now going up to about 40%. You see the settings there. You see the ABG. Again, we have respiratory acidosis with a little bit more metabolic acidosis. The X-ray shows ground glass appearance. Everybody knows exactly what this means. This is respiratory distress syndrome. Should this get surfactant? Again, we'll talk about that. How should we give that surfactant? Should we get mechanical ventilation? So again, same idea. We're on 40%. If this kid was on 80%, you guys know the answer. I wouldn't be presenting that. But this kid's on 40%. So we know we probably want to give surfactant. Is there a way to do that? And do we have to balance out the trauma of intubation, or is there something better? Of course, I'm here to tell you there is something better. This is thin catheter surfactant administration, TCA. This is the big term, the big umbrella term for what everybody knows as LISA or LISA, right? But that's one thing. You actually have LISA, which is less invasive. You have LIST, which is less invasive surfactant therapy versus administration. You have MIST, which is minimally invasive surfactant therapy. Why is this important? Because again, you go to different countries, you go to different units, and some people say, oh, we don't do LISA, we do MIST. I might tell them, it's the same thing. You're just using a different catheter, right? So that's why when I give this talk, I just basically say, what type of TCA do you do? Okay, thin catheter administration. But it's the same thing. And a lot of the times when you go to listen to these talks, everybody will say, we do LISA, but it's actually MIST. But LISA has become just a bigger term. It's become like the umbrella term, but there is actually a bigger umbrella, TCA. All right, so you insert the laryngoscope. Keep in mind, you're still intubating, right? To a certain degree. You're still placing a tube. Intubate, that doesn't mean intubate with an ET tube. It's you're putting a tube, it just happens to be thinner. You're still needing to use a laryngoscope. You still need to be an expert to be able to do this. You still need to get those multiple attempts and the 10,000 hours that Michael was talking about to be able to become proficient, okay? The McGill forceps are used to insert a thin catheter. In the case of LISA, with a direct observation, you're actually using a thinner catheter, an angiocath for MIST. It does minimize the trauma for ET tube. That is the big part of what is LISA or a TCA, is that you have less problems with that. As I'll show you, you also have a decrease in comparison to insure. You have a decrease in BPD. And I get questioned all the time, why would BPD be less if you're still intubating, you're just doing it with a smaller tube? And the hypothesis is that you don't need the positive pressure that you do in an ET tube. So as you're using a thin catheter, you're basically letting gravity trickle in versus the positive pressure ventilation that you assist. Again, the counter arguments for experts is, well, is 5 or 10 positive pressure breaths enough to cause BPD? And studies have shown that actually, yes, in the delivery room for these extremely preterm infants, 5 to 10 positive pressure breaths can make a difference and increase the risk of BPD. So RIGO in 2016, as I mentioned, showed that, and you can see the number needed to treat being 15 of 0.724, so 74, sorry. So that's very, very adequate. And then obviously the need for intubation was down to 0.67, or number needed to treat, which is 8. So huge, right? So it does show a big effect in compared to insure when you're looking at BPD and death. Okay, if we look at this forest plot, it's what I already talked about. When you're looking at BPD death, you see that it's on the left, early CPAP failure as well. When you're looking at MIST, and again, same thing, the idea, so that people don't think I'm biased towards LISA. No, we missed at TCA. So you can actually see that in these babies, well, the two categories, 25 to 28 and 29 to 32, as you administer the LISA, you can actually see that the CPAP pressure decreases in both. You can also see that immediately the FiO2 decreases. So this is clinically relevant. One really important piece of warning by DeLuca was a study where he looked at the radius, and this is something to keep in mind. This is the radius, of the bronchoscope, and when you're looking at a term infant, the feeding tube radius is much smaller. So that's good, but it also adds resistance. So if you try and push that, you're gonna get a higher flow, which can cause some minimal damage. This is why it's really important not to force the surfactant when you're doing some type of a TCA. But what's more important than that is that the Lucas showed that, as I already mentioned, you're still intubating. You still can have decrease or changes in vital signs. You still can have a cortisol response to that, which, as we know, can change the blood pressure in your brain. And as we know, especially with these smaller ones early on, they don't auto-regulate the blood pressure. So the blood pressure, intracranial pressure, goes up. In an older child, you'll vasoconstrict to keep that ICP, the intracranial pressure, the same. In a small baby, 25 weeker, within those hours, they don't do that. So that pressure goes up, it's gonna go up. That's where you get IVH. All right, let's talk about case 3 now. So this is a term baby born with some D cells, fetal bradycardia, rupture of membranes, thick meconium, is admitted to the small community hospital, right? This is an important case because the pediatrician actually tries to intubate 3 times, but is unsuccessful, okay? They've intubated one a year. They have this unfortunate case of a very bad meconium aspiration, PPHN. They just don't have the experience, and we can't blame them. I hear all the time, we get these transfers from the community, and the residents will say, oh, I can't believe it, or the fellows, oh, I can't believe it. If you don't have the experience, sometimes it's even better not to. But is there something better? You guys know the answer. Yes, there is. So, or at least I think so. So the baby was placed on non-invasive ventilation. You see the settings there. Again, the ABG, similar story. You have this reticular pattern. This is meconium aspiration syndrome. So what does that pediatrician do? Do you say, I'm going to stop intubating because I'm going to damage, and I will transfer this kid on NIPPV without giving surfactant because I can't do it, right? But that FiO2 is already at 80%. You know, this is not good. The excellent talk on pulmonary hypertension just right before me talked about the higher you go on your FiO2, you're gonna not only have pulmonary hypertension from the meconium aspiration syndrome, you're also now gonna induce some of that. And how scary is it for a transfer that you have to go 2, 3, 4 hours with that FiO2? Very, very scary. So do you keep trying to intubate? Does that pediatrician say, you know, I got to try because I'm really, you know, I've got to get this done. And is there another way? And again, you guys know there is. So this is where SALSA comes in. So SALSA was turned by 2 doctors and myself. So Dr. Carrie Roberts and Dr. Guthrie, Scott Guthrie from Vanderbilt, from Minnesota. And again, myself, we got together. We are not the first ones to do this study. I want to get that right. We coined the term. We're not the inventors of SALSA. Okay, this was actually been studied for 10 years. Dr. Guthrie and Dr. Carrie Roberts. Carrie Roberts actually, I'll show you, did the largest study. And she reached out to 2 of us to be able to come up with a term that can encompass how you deliver surfactant when you're not using an LMA, when you're not inserting something. Because there had been different methods of giving surfactant through an LMA, but they were coined different things. They were termed different things. So the literature was out there, but there was no one common way of putting it together. So this is where we came up with the term SALSA. So this is the installation, again, of surfactant through a laryngeal mask. We use a thin catheter placed inside. I'm going to show videos. For this, okay? Because I think a picture is worth 1,000 words, a video is worth 1,000,000. You instill 2 millimeters maximum, and then you actually do bag that into the patient. Then you remove the LMA, and there is no need to take out the CPAP. So that's the one great thing about it. You can actually continue to give continuous pressure, so you don't, lose those pressures. And the other thing is, if you have an OG, you don't need to remove it. I know for a lot of intubations, a lot of people remove the OG or NG. You don't need to in this case. Okay, so let me see. Let me see if hopefully this will play. If I play this, here, my friend, if I play this, will it? There should be a click on that.
We can imagine that we have our baby, that it has respiratory distress syndrome,
You guys hear that?
currently with the nasal CPAP. However, you can use your own hospital's device if you need to.
Those hands look familiar?
The next step is cutting. In this case, we have a T-connector. We can also use, this has already been cut, but we can use a nasogastric tube.
So you can actually,
As an example,
this is a very short video.
we can cut the T-connector to approximately 6 centimeters, or enough that it will enter the laryngeal mask airway about halfway. As you can see, with the T-connector, it's inserted approximately halfway. And it can be somewhere in between. What you don't want is anything coming out through the mouth. Now we're ready to insert the laryngeal mask airway. The way to insert the LMA is to point the tip of the mouth towards the nose, but enter through the mouth like so, against the palate of the baby. Once you enter, you're gonna hit the curve of the palate, and you may feel some resistance at the back of the palate as the LMA curves. Just continue to put some constant pressure until you feel like it's lodged in perfect place. To confirm that it's in the right place, we can use now our CO2 detector with our T-piece by giving a couple of breaths. You want to do the next part as quick as possible because right now we are obstructing the airway. We can now attach our cut NG tube to the syringe. In this case, we have 6 milliliters, and we will be giving 2 milliliters at a time.
So in this case that I'm showing you, that's why
we'll start with the 2 milliliters, and at that point, immediately connect your CPAP device and give a few breaths. Then we will repeat the next step. You can give about 10 breaths, making sure again that there is no surfactant coming up through the LMA. There may be some surfactant bubbling or some bubbling, extra bubbling in the mouth. We can remove that or clean the baby's mouth like so. At this point, you put constant pressure outwards, following the curvature of the palate, and you remove it gently like so, making sure, again, if there is any surfactant that has come up, that you suction the mouth. Throughout all these steps, you are following the vital signs of the baby, making sure that between given surfactant, the baby is stable. Follow all your processes and guidelines and hospital rules, like you normally would if you were given surfactant through an endotracheal tube.
You know, the first time you do it, you don't know what you're looking at. The first time you insert an LMA, you're not sure it's in the right place and all that, but it's the easiest thing to do. Okay.
We can imagine that
So what is the evidence behind this, right? Because again, we're trying to teach this, but what is the evidence behind this? This is one of those things, we don't have a massive randomized control trial. I was talking to Michael about this because I've given this talk in multiple countries. And, you know, the one thing I always hear, and you'll see that, is that, oh, where is the 1,500, 2,000, you know, randomized control trial so we can put it into practice? And I tell them sometimes there is a great study that was never done, which is if you jump out, it's a randomized control trial of jumping out of a plane with a parachute and without a parachute. Okay, that study will never be done because you know that if you jump with a parachute, you will survive. If you jump without one, you will not 100% of the time. So some studies, when they're so successful and they're, you know that it shows, you know, minimal problems, minimal invasive, anything like that, and shows improvement, you don't need to do a huge amount of studies to be able to prove this. You can actually go with some smaller studies. So this is what's been done. And so Zucchini in 2015 was a smaller randomized trial of 35 using insure, comparing insure or an ET tube. These babies were on CPAP, and where the criteria for entry was 30%. They were given surfactant. The failure, if it didn't work, was of 70 FiO2 or that gas. As you can see, the average time that was given for this procedure was about 5 hours of life, and the procedure time was approximately 5 minutes. That was actually one of the first studies. Okay, we have now done subsequent studies where we've actually looked at intubation versus SALSA, and the SALSA takes about 35 seconds, while the intubation took 1 minute and 35 seconds, okay? We've also done studies where this is given as a first time with residents, and they're able to do it successfully. I'll show you that in a minute. We've also done studies where the nurses have inserted the LMA and given surfactant for the first time. They had never done an intubation or an LMA, and they were successful 100% of the time. That's we haven't published that because it's more of anecdotal. Robert's study is the biggest study. So this is 2015, which is 50 patients for each control, 50 and 53 for the control. What we showed was that the mechanical rates and the intubation actually in comparison to the LMA versus CPAP was versus intubation, sorry, was 38% versus 64. I'll show you that in a second. And the controls for an odds ratio was 0.3, which is really, really good. Calibo in 2018 did actually a systematic analysis, and this was 5 randomized controlled trials, and it actually showed the decrease for the need for intubation mechanical ventilation when using CPAP alone, and when you were comparing to insure. So this is a study I was talking about from my good friend Carrie Roberts. So you can see again the decrease in treatment failure from 64% to 38%. Again, this is in comparison to insure. One of the things we really need to look at, and again, you guys are probably going to ask me about that, is what about comparing with Lisa? So there's an ongoing studies for that. Okay, so we don't have that data just yet. This is the equipment that you need. So you can tell there's different types of LMAs. Some of them you will insert, you insufflate the cuff, and then you give your surfactant. Other ones, like the iGel, for example, you don't insufflate. This is the equipment needed. We did that one video. So let me jump to this video quickly. I've got a few more minutes. So this is, as you can tell, an actual patient. This is courtesy of Dr. Roberts. I think there's volume, maybe not. Okay. So this is a device with a side port. So you can see this baby has been intubated. You can see the capnography on that. So you can tell that you are in the tracheal space because you'll immediately turn the color, just like we do in an intubation. The color will turn, showing you you're in the tracheal space. You use a side port. Try not to disconnect the back. You use a side port to be able to deliver the surfactant very, very quickly. You're giving the surfactant. You are doing some bagging, similar to what you would do with a tube. That's how easy it is to remove. And then like an intubation, sometimes you do get a little bit of liquid come back, a little bit of liquid surfactant come back. But in the studies, we will actually pull, and clinically you can do this too. If you have an OG in place or an NG in place, you can pull out to see if you have any remaining surfactant in the stomach. Then if you have a substantial amount, then you can actually repeat that procedure immediately. But in the study that we've looked at, you rarely, I mean, if you have, it's a combination of little gastric juice with that. Okay, final case. I'll go really quickly with this. We have a 33-weeker on CPAP, is admitted on CPAP on 30% FiO2, but then later we go to 40% FiO2. Do we continue to go up and up and up in the settings? Do we intubate, give surfactant, or is there another way? And of course, there is another way, and this is aerosolized surfactant. So this is Dr. Sood's study. This was one of the first studies. It was a very, very small number of babies using a different device. It wasn't very effective, and I think that really had to do a lot with the device per se. So when this was this study first came out, a lot of people were really disappointed because we think, oh, aerosolized is the future of surfactant delivery, and it was very disappointing results. So there was that concern of maybe this isn't the future. But this is a study that I participated in, and essentially it was one of the largest studies that we have right now, 464 patients for aerosolized surfactant. You had the non-intubated. There was 2 cohorts. Basically, one, if you had never been intubated and given surfactant, you were you were in cohort 1 if you gave the surfactant below 12 hours. The other one, if you had gotten surfactant in the delivery room, you had up to 24 hours to give it. And we used an FiO2 initially of 25 to 40%, but then different centers use different CPAP levels. So we realized that some people were cranking the CPAP to 10 just to get down to, those levels. So we realized, you know what, let's just use less than 40. This is how good. So 15 minutes before aerosolized surfactant, and this is 45 minutes before aerosolized surfactant. So clinically, we're seeing an improvement. This is the actual generator for aerosolized surfactant. This needs to be given with Invasurf. Okay. And a lot of places where I go to, they say, well, why can't we use Curacao? Why not? We don't use InfaSurf in this place. So unfortunately, the other surfactants, they actually they're blended, right? They're cut alveolus and meat inside the surfactant. If you haven't realized that when you're doing Curacao, when you're doing other things, you've got pieces in there. Now they're minute. And in the grand majority, in the grand scheme of giving a liquid surfactant, no big deal. When you're aerosolizing, you have those particles are too heavy and will actually pull your surfactant. So a lot of it, if you're using other stuff, the meat won't actually go through that tubing. Okay, it's like a spray. You need to have very, very small. So because of the pieces, you can't go through that tubing. But if it does, it will actually just stay up in the airway because it's so heavy. So InfaSurf is the only one that doesn't, is the lavage, right? So they don't have pieces of meat. So that actually allows you to get all the way to the bottom. You know how it's given? With a passy. You have a baby, just put a little pacifier to his mouth and suck. That's all they're doing. They have no idea. They're saying, oh, this is great. This is the best medication. I mean, imagine all the medications if we could give epinephrine through a passy. You know, that would be great. So you give surfactant through a passy, and here it is. That's all they're doing. That's surfactant delivery, and we hope that this is the future. This is a great study. Okay, with that, again, I had the picture. Hopefully you guys can go on the Instagram and check it out. But I want to thank you for your time, and I'll be happy to take questions later.